Hi, this is Professor Hale. I'll be covering Chapter 29, Child with Mental Health Condition, and this is in your Safe Maternity and Pediatric Nursing Care textbook. About 20% of children in the United States are suffering from a form of mental illness and a disorder that is significantly interferes with the daily life of a child and a family associated. Common factors in mental illness include parenting, family dynamics, hereditary stressors, biological chemistry, and psychological trauma. So it is really important to identify the abilities and behaviors that are considered normal for the child's age. So when ruling out mental illness, you must determine how the child copes with setbacks and adapts to changes and relates to others and the world within their context of his or her development stage and age. So early identification and treatment with psychotherapy and medication increases the chance of full productive life. Adverse child experiences are found to be related to future health depression, which they can have depression, anxiety, and diabetes, cancer in their adult life. They're more prone to violence, victimization, risky behaviors they could have as they go into adults, such as trucks, and puts them at high risk for sexually transmitted infections. Low potential, which is low life potential, which is puts them high risk for substance use disorder, and early death, which is ultimately suicide. Protective factors can reduce the impact of child trauma across the lifespan. Goals for therapeutic communication between the nurse and the child and family during the acute phase of mental health conditions. It is establishing a rapport of a child with acute exacerbation of a mental illness, and that is a priority action. And also ensuring safety, other safeties, and you're safe. Building trust, communicating the importance of interventions to help the child cope with and recover. What places so another thing with child, you have to really monitor them for suicide ideations or thoughts. What places them in the high risk? Usually children diagnosed with mood disorders, depression, and anxiety, and especially teens with eating disorders. They are at high risk for self-harm. So, you know, they may be coming in with behaviors or self-harm behaviors like cutting. They may participate in violence. They'll have like suicide ideation or attempts. So any any inclination of that or any suspicion of that is you must be acted on immediately. So in order to provide holistic care in an acute phase or a mental health and for mental health disorder is to quickly identify the underlying mental disorder and the severity. Usually assessments include, obtaining history, child's history, getting the medications that are currently prescribed, precipitating factors, or current mental state. So attention deficit hyperactivity disorder, which is ADHD, is a neurobehavioral psychiatric disorder, and it's one of the most common mental disorders diagnosed in both children and adolescents. ADHD persists in adulthood for up to 60% of those diagnoses that are diagnosed. And children with ADHD, they usually have difficulty focusing on schoolwork and activities at home and controlling their behavior, which is they're very impulsive, having a hard time paying attention or relating to others. Usually between 6 to 11% of school-age children in the United States have a diagnosis of ADHD, and it's more prevalent in males. Usually 1 in 5 boys and 1 in 11 girls have diagnosis of ADHD. There continues to be no single test to accurately diagnose ADHD in children. So, brain imaging has revealed that ADHD may be associated with how the brain is neurologically wired and physically structured. A significant developmental delay, as much as 3 years, in the frontal cortex is related to ADHD. The frontal cortex normally suppresses inappropriate actions, displays focus, attention, and controls movement by movement memory. And research continues to internationally determine the erratices of disorders, and the best treatments across the lifespan is to maintain safety for the child with ADHD. Usually, there are three different main types of ADHD, which is predominantly inattentive, which is challenging for the child to concentrate, finishing a task, or follow conversations or academic instructions because they are easily distracted. There's predominantly hyperactive impulsive, so that means a child struggles to sit still. They keep, his or hands to themselves, or you know, or herself, and they interrupt frequently and fidgets and squirms, and they talk nonstop. Then there's the combined presentation, and it includes behavior listed in both of the preceding types. Usually because of ADHD, it often affects both school and home behaviors, and children with a disorder need a combination of therapies. Management must first include behavior therapy, including parent training or home behaviors, classroom behavior management, peer interventions that focus on child's behavior, or neurofeedback training, social skills training, and cognitive training. Further treatment includes medication with the central nervous system, and which stimulates and which include the stimulants and non-stimulant drugs, which are not they're not rapid acting, but they last 24 hours. So, and that's that. So when we're going to evaluate, usually when according to the Diagnostic and Statistical Manual of Mental Disorders, a child has to be diagnosed with ADHD and have at least 6 of the following 9 symptoms listed below. So symptoms must be presented, such as fidgets with fingers and hands and objects, often leaves his or her seat in the classroom when expectations are to stay seated, experiences forgetfulness at school with homework assignments and at home with daily activities, becomes easily distracted and excited when distracted, seems to have not to listen, and does not follow through with explained expectations or desired actions. Continue on. Usually they talk excessively, they interrupt, they intrude in others' conversations, and they don't wait for their turn. They have a hard time, they can't pay attention to detail and make frequent careless mistakes, and they have difficulty playing quietly and has problems focusing. So they're all over the place. So many professionals offer parenting suggestions for raising children with ADHD, such as includes positive parenting, praise for task completion, promotion of creativity and talents, and well-defined schedules. Interventions for ADHD are generally pharmaceutical in nature. Alternative and complementary interventions for children with ADHD typically consist of structured and frequent exercise, but standard of medical care is use of medications and which help that child focus and be successful in school. The following are common medications prescribed for children, which are Ritalin, Concerta, usually Daytrana, or amphetamine, like Adderall or Adderall XR. XR is like extended release. Or we have Vyvanse. So there's or Strattera, Wellbutrin. So those are the things that you got to really be mindful. Those are in your book. You can actually see them and review them. It's good to know how they act. It's pretty much, obviously helps them stay focused. And sometimes they only take them for the school periods of months. The short acting ones, they usually give them, just during school months, and then sometimes at summers they will take them off the medications as well. And here are the most common medications that are prescribed for children with ADHD. Usually when you see the XR, that's extended release. Most times providers will prescribe these medications more in school months, so they can actually focus on their school in their curriculum. Usually parents, they might express concern about administering medications to help them control symptoms of ADHD. So it's important to teach the family about the importance of the medications and its side effects. Especially when you see the Pemoline, the Thylert, that is requires like a liver function test because it's associated with life-threatening liver failure. Also, you want to assess if there is like a complete multimodal approach to the child's care. So this includes behavior modifications, parental educations, and hands-on training classroom accommodations, such as like with social skills training and families adaptive participation in local, regional, and national organizations. So here are some further nursing considerations as a nurse for you when you're caring for children with ADHD. Support and educate parents. You need to have patience. Provide information on local and national support groups, as I mentioned, and organizations. Excuse me. You want to assess for the side effects associated with the use of psychostimulant therapy, additional family instruction of caffeine decongestants, and the monoamine oxidase inhibitors, which is the MAOIs, and Pemoline. So you want to be mindful of those typical medications, type of medications. And also you want to, in your textbook, you can see the patient teaching guidelines as far as with the medications in children with ADHD. Also, you want to include the side effects for the medications. I want to add, which are, they can include like decreased appetite, nervousness, insomnia, weight loss, tics, headaches, and stomach aches. And that's with the psychostimulant therapy with those medications. Also, be mindful when children with ADHD who are hospitalized, they may have worsening symptoms like mood swings and aggression. So you just want to be very mindful of that when you're caring for children like that, because you really need to be patient and you need to, approach them accordingly. Okay, now we're going to discuss autism spectrum disorder. So autism spectrum disorder is a pervasive developmental disorder. The prevalence of ASD is thought to be 1 in 59 children. And in autism, it is more common in males than in females with a ratio of 4 to 1. Autism spectrum disorder is found in all races and ethnicities, and with non-Hispanic Caucasian children, usually they have the highest rates. The current definition of autism spectrum disorder encompasses conditions such as Rett syndromes, which is a brain communication, motor, and growth disorder, and Asperger's syndrome, which is a mild form of autism. So there is no known cause for autism, but it is known to exist from birth with early symptoms noted as early as late infancy. And the condition is characterized by pervasive and severe impairment in the child's communication skills and social interaction, and it may be accompanied by repetitive and restrictive behaviors. The child usually will not relate comfortably with others and does not want to be touched, cuddled, or comforted by others. 10% of the children with autism spectrum disorder have a coexisting chromosomal genetic condition, such as Down syndrome, tuberous sclerosis, or Fragile X syndrome. Usually about 44% of those with autism spectrum disorder have above average intellect. Here we have the characteristics that I just mentioned. So, when working with children with autism spectrum in a healthcare setting, you want to include following like minimize touch and explain to the child when the touch is needed. You want to give the autistic child time to prepare for the next activity. Understand that autistic children may be withdrawn and quiet, and acknowledge the autistic children that may have trouble with interpersonal relations, like including avoiding eye contact and having unusual language disturbances, and stress to the parents and that the autistic child may feel overwhelmed in a new environment. Characteristics is like we already mentioned that, already discussed that. And here are the symptoms. We already discussed that they have the minimal interaction with others. They may not respond to their own name. They have a desire for limited touching and cuddling or molding. Minimal display of anticipatory behaviors, which we already went over that as well. So you got to be mindful of as when we mentioned it in class and we're discussing that, all the high stimulation and the noises and all that, it's just not just being annoying to them. Any noise or anything like that, or an excitable environment like that can be very painful. It's considered as it's painful for that child. So the more chaos and the more stimulants that child is immersed in, it's going to be painful for them. So we got to make sure we got to reduce that by placing them. If they're in the ER, you want to make sure that they're in a quiet room. You have to approach them accordingly. Include the mother or the caregiver with that child, because they know how to approach them. They already have that rapport, that trust with that child. So you definitely want to include them in the care when they are in a healthcare setting, especially in the ER setting. We always make sure, when I was in the ER, we always make sure that they are in a quiet room away from others, so they don't have to, because it's a chaotic environment. It's a lot of stimulation going on in that department. So we want to make sure we can reduce as much as possible and make the child comfortable. Evaluating, usually it's the appearance of being deaf without the hearing impairment, abnormal responses to stimuli and lack of focus, socially awkward or acceptable behaviors and repetitive rhythmic motions, distress and resistance to changes in daily routines, their marked need for the sameness and attachment to objects. Interventions, usually there's no treatments or cures. Usually it's a combination of therapies. Pharmacotherapy for anxiety, depression, or OCD disorders if the symptoms are present. So those are pretty much what that, and usually that's pretty much it really, as far as interventions for that. Again, as I mentioned, when working with children with autism spectrum disorder in a healthcare setting, you want to go in your textbook, and you can see the safe and effective nursing care in your textbook. That has all the information in there as well. So if you read your chapters, you should be fine for your exam. All the content, all the questions are related in whatever's in the chapters. Nursing considerations, you want to have one-on-one care. You want to give directions without rationales. You want to minimize touch, provide a calm and non-stimulating environment, and you want to be very supportive and empathetic to the parents. So eating disorders are on the rise in both males and females. Eating disorders are serious and they may be dangerous or fatal if not identified early, or if they're not medically treated. Often associated with poor self-image, poor self-esteem, very poor perception of physical self. There are 6 types of common feeding and eating disorders, which are anorexia nervosa, avoidant restrictive food intake disorder, binge eating disorder, bulimia nervosa, pica, and rumination disorder. So those are the most common ones that we're going to be discussing in this portion. So we're going to start with anorexia. It's the cause of anorexia nervosa is unknown. Risk factors include negative self-image, problems eating during the infancy, anxiety disorder, abundant focus on rules and achievements they usually have, and they're trying to be perfect all the time. So those who suffer from this eating disorder have a preoccupation with food. They're obsessed with it and their body shape and the weight. Diagnosed criteria for anorexia nervosa include 4 main attributes, which is children voluntarily refuse to maintain a normal body weight for their age, height and size, and weighed 85% or less of the expected normal weight. They have a tremendous fear of gaining weight. They view themselves as fat even when they're being significantly underweight, and they deny their condition. They maintain a disturbingly poor body image, and they do not recognize the seriousness of their condition. Females will experience amenorrhea, which is the absence of at least 3 menstrual periods in a row. So that would, and then usually diagnosed criteria, they voluntarily refuse to maintain a NAB. So we already discussed that. They deny to have any recognized seriousness condition. So I already discussed that in the previous slide. So bulimia is characterized by an excessive appetite and insatiable eating, recurrent episodes of binge eating followed by guilt, humiliation, shame, and then self-induced vomiting, dieting, and exercise. So the child will try to cover up or hide their behaviors, and the child or the teen is usually a normal weight. But bulimia, like I said, it is another common eating disorder. And this is when they eat a huge number of calories, as followed by purging behaviors of enemas, laxative, diuretics, or self-induced vomiting behaviors. Sometimes they'll have like extreme exercise or a combination of them. And then we're going to move on to the binge eating disorder. This is a consumption of large amounts of food and calories. They often they just eat very rapidly and quickly, with a feeling of being out of control, and they're just unable to stop. Many people who suffer from this disorder recognize that their behavior is out of control. They usually feel disgusted and ashamed of what they did, and follows with upset and guilt, and usually they're not able to stop. Complications with this eating disorder includes obesity, social isolation, problems with school and work, and developmental of chronic illness. And avoidant restrictive food intake disorder, it's another type of eating disorder, which is a restrictive type. The child participates in episodes of food restriction and severe calorie reduction. So this disorder prevents food consumption outright. And another eating disorder is called pica. This is when a child persistently consumes non-food materials. It's usually associated with developmental disability and cognitive impairment. Complications with this can include bowel obstructions from eating non-food items, and anemia, which that occurs when a child eats dangerous substances like paint chips, toxic plant materials, or sharp or hard objects. Diagnosis, it requires pica behavior to be present for no less than 30 days. And treatment includes behavioral modification and mild aversion therapy. So when evaluating eating disorders, assessment should include plotting a child's weight on weight and height on a national growth chart. Further assessment is warranted if it's significantly under or over the expected weight. You want to draw metabolic panels, lipid panels, or electrolyte panels. Test for lead or other toxins if the child's engaged in pica. CBC testing for anemia, mostly if and excess blood pressure, cardiac function, EKG. Assess the use for laxatives, diuretics, enemas, and diet pills. And you also want to report any of this use immediately to the healthcare provider. Further assessments include to look for evidence of malnutrition. So when you see somebody, a child or teenager, they have the thinning hair, which is called lanugo. So, lanugo is like when you see a baby, they have that really nice fine hair when they're born. So that's called lanugo. That is more prominent in anorexia nervosa. Hair loss, brittle fingernails, dry skin, enamel loss on the teeth, and that's from purging. Amenorrhea, which is absence of menses. Mood changes, bradycardia, hypothermia or cold intolerance. Teenagers' loss of libido, They'll have the Russell signs, which are the bite marks on the fingers and knuckles, which may be present from a child, and this is that are inducing vomiting. So interventions for eating disorders, like many mental health conditions found in children or childhood, treatment for eating disorders is considered multimodal and it requires lengthy interventions. That includes psychotherapy, which is the mainstay of treatment, and it includes behavior modification. Medications such as antidepressants, they may be required to support the child, and other interventions are specific to the type of the eating disorder treated. Nursing considerations. The nurse needs to understand that anxiety is associated with eating for the child with eating disorder. These children may become angry, disruptive, and manipulative in order to avoid consuming calories, to binge in secret, or to eat their preferred non-food substance. So make sure the child does not have any opportunity to purge, vomit after meals, or to engage in harmful eating behaviors. The nursing goals for the children with eating disorders include securing weight within the 10% of the expected for age and height, um, resolving underlying emotional and psychological problems, correcting malnutrition, which is preventing severe consequences such as type 2 diabetes, anemia. They can have electrolyte and cardiac dysfunction, and assisting with treatment plan to restore the child's perception of health and body image. Left untreated, eating disorders can be fatal. Therefore, it is imperative to identify and treat them early. Parents must be educated on the need to participate fully in therapy. And nurses, they can be instrumental in becoming involved in adolescent education and prevention through the community action. And here are further nursing considerations, which we discussed in the previous slide. So I'm not going to go over this extensively. Moving on. So now we're moving on to anxiety. Anxiety begins in infancy and the form of separation anxiety, and that occurs between ages 7 to 8 months. Childhood anxiety disorders are becoming more common across all ages, and it requires an evaluation of persistent throughout the childhood and interferes with social and academic and normal cognitive development. There's different subtypes of anxiety disorders, which are separation anxiety disorder. So that disorder differs from the separation anxiety in infant, commonly experiences in the older child that has unrealistic anxiety and persistent worry that harm will befall on him or her if separated from the primary caregiver. So this includes resistance to attending school or social events or even going to sleep. And then next we have generalized anxiety. With this disorder, children worry excessively about the future events, competence, or previous behavior. Often generalized anxiety is demonstrated through physical complaints and great difficulty of relaxing. Sometimes they may have GI upsets or anything, GI symptoms, gastrointestinal symptoms. Panic disorders. Children feel overwhelming sense of worry and panic. They may present with physical symptoms of increased heart rate, sweating, and increased blood pressure. Then we have phobias. They're a type of anxiety that is experienced only under a specific condition that the child will try to avoid. Then we have the post-traumatic stress disorder, PTSD. This disorder, anxiety, results from an external traumatic event that was perceived by a childhood or adolescence as very dangerous or life-threatening, like intrusive and recurrent recollections of that occurs, which causes the child extreme distress. This distress can be demonstrated through sleep disorders, sadness, and feelings of helplessness, and vulnerability. And then we have the obsessive compulsive disorder, OCD, is marked by a child's persistent repetitive thoughts, repetitive rituals, or repetitive movements that do not contribute to social acceptance with family, peers, and members of society. Evaluating Nurses working with a team of healthcare providers can provide assistance in conducting assessments for anxiety disorders. Assessments for anxiety disorders include the following, which is a biophysical assessment of vital signs for tachycardia and tachypnea with shortness of breath, gastrointestinal symptoms, neurological symptoms, sleep disturbances, um, poor school performance and decreased participation in age-appropriate activities, poor self-esteem, use of drugs or alcohol. Interventions for anxiety. Children need professional counseling to deal with anxiety disorder. So the goal is to increase their self-esteem and to teach them relaxation exercises and self-regulation to address their feelings and anxiety. School-aged and older children may be able to conduct self-help exercises to reduce their anxiety. And these include verbalization of feelings, exercise, deep breathing, visualization, relaxation techniques, and problem-solving techniques. So when moderate anxiety exists, the child needs a referral for cognitive behavioral therapy interventions. And if the child has severe anxiety therapy and possibly anti-anxiety medications are usually called for as well. Interventions for anxiety, usually moderate, they usually need a referral for, like as I discussed before, for moderate, they need a referral for cognitive behavioral. For severe, that's when medications will be ordered as well, prescribed. So I already discussed that in the previous slide. So moving on to the nursing considerations for anxiety, you want to involve child life specialists and staff pediatric psychologists with sudden increase of symptoms, help reduce symptoms. You want to assist the anxious child by staying right with him or her. You want to maintain a calm and relaxed approach, by offering positive reinforcement, meditation, prayer, and alternative therapies. Moving on to mood disorders, which is we'll begin with bipolar disorder. It is characterized by altering mania and depression or rapid cycling of moods. Children with disorder may experience grandiose thoughts, pressured speech, extreme irritability, emotionality, distractibility, and high levels of activity. And it's usually often at bedtime. Treatment for bipolar disorder is lithium carbonate. Now, this medication prevents or decreases the incidence of acute manic episodes. Therapeutic levels of this medication must be tracked by the serum levels, with an ideal level of being 1 to 1.2 milliequivalent per liter for initial treatment, followed by 0.5 to 0.8 milliequivalent per liter for maintenance. The most common side effects associated with administration of lithium are fatigue, headache, impaired memory, ataxia, abdominal pain, dry mouth, and tremors. But once this medication is started, therapeutic effects can take up to 5 to 7 days. And these are the common side effects right here. We already discussed those. Persistent depressive disorder. It's characterized by periods of major depression and normal mood lasting several days or weeks. It may be presented with pre-existing disorders such as somatization disorder, anxiety disorder, or anorexia nervosa. May appear to be passive, dependent, and lonely, or aggressive, angry, and negative. And treatment for persistent depressive disorder are antidepressants. Another mood disorder is depression. So depression, it's not a state of sadness. It's actually a serious medical illness that affects young children and teens. Incidences of depression in children is increasing, and It is really imperative that a nurse can identify symptoms and assist in formal assessment and secure treatment as soon as possible. The best way to identify depression in children and teens is to regular screen for symptoms. The depression scale for children takes only about 3 to 5 minutes to administer, and it is considered quite sensitive in detecting depression. So the cause of depression in children is unknown, but there may be an imbalance of brain chemistry, or it may be associated with other illness, substance abuse, or environmental influences. Stressful events such as death, divorce, parents are getting divorced, or they move move away from the family, or severe illness may trigger depression. And depression also can be hereditary link. So childhood depression is not considered normal or associated with life's experiences. It is a medical diagnosis with severe symptoms and consequences that require immediate medical attention. Early treatment may help avoid the depression getting worse, extending for a long period of time, or becoming a lifetime challenge. And as we said, early treatment may help avoid depression from getting worse. And I already discussed that in the previous slide, so I'm moving on to the next. Signs and symptoms of depression include they feel hopelessness, sad or angry. They demonstrate a loss of interest in activities that they usually enjoy. Physical symptoms like fatigue, sleep disturbances, appetite disturbances, muscle aches and headaches, and also frequent crying spells. Depression, when you're evaluating depression in different developmental stages, you can see in preschool, there's usually weight loss, and they usually have weight loss and a lack of interest in play. School-age children have trouble concentrating at school, paying attention, making decisions, and recalling information. They're less confident. They always state that they can't do anything right. Adolescents, they have poor hygiene, like they don't want to shower for a long time, or they stop communicating with friends and family. They lose interest in teen life and activities, and also this is when they will have their suicidal thoughts as well. Interventions for depression includes counseling, antidepressants to help balance the natural chemicals like the neurotransmitters in the brain, psychotherapy, serum levels of psychiatric drugs. You want to see the labs and diagnostics in your chapter, in chapter 27, when it comes to medications, and that is on page 535. So I recommend you to see those as well to review them. Herbal remedies, sunscreen, or psychotherapeutic medications. You also want to see in your chapter 27 of the health promotion. So your nursing considerations for depression is to monitor social isolation, increasing symptoms with hospitalization, and potential for self-harm. Include the child life department, ensure plan for the child and family participation, administer antidepressants medications on time, and know their side effects and safety precautions, because a lot of these medications you have to probably monitor some lab serum, and there's a lot of education, so it's always important to know the side effects, what the medications do, their effects, and what to educate them on. Follow general guidelines for families with child with depression. So here's a little thing: newer antidepressants, they usually have fewer side effects in children than older medications that they used to take. But side effects should still be monitored and reported immediately to the prescribing healthcare provider. These common side effects include nausea, headaches, drowsiness or sleepiness, agitation with jitters, constipation, dry mouth, and blurred visions. The MAOI antidepressants, they can cause dangerous side effects if the child ingests a food or a drug that contains tyramine. And when a child ingests like tyramine, it's while on MAOIs, a sharp increase in the blood pressure may occur, which has been associated with cerebral vascular accidents like stroke. So families must be taught that aged cheeses, cured meats, pickles, wine, over-the-counter decongestants can contain tyramine. So you really want to, that's a big thing. So be aware of those types of medications. So, suicide in childhood, suicide is defined as death by taking one's own life. It is the second leading cause of loss of life for children, adolescents, and young adults, ages from 5 to 24 years of age. There are three main causes of death associated with suicide, which are gunshot, strangulation, suffocation, or hanging, and poisoning. Suicide attempts in children are far more common than lethal suicides, with up to 7% of children having at least one attempt to kill themselves. And this is between ninth and 12th grades. Almost twice as many female students attempt suicide than male students do. Also, in addition, families that are experiencing marital difficulties, child abuse, or substance abuse are more likely to have adolescents who are at high risk for suicide. In addition, in 1/3 of adolescent suicide cases, usually a parent or a sibling or a first-degree family member has expressed suicide thoughts, engaged in suicide gestures, or has committed suicide. Um, Usually, there are common terms associated with suicide, which are suicidal thinking. And this is when a child or teen is thinking about suicide but has no plan. This is not uncommon, with about 3% of the general teen population reporting suicidal thinking at one point in their development. Then we have the suicidal ideation, the children and teens who have thought out a plan, but have not carried out any behaviors towards suicide. An example would be a teen who is collecting pills but has not made a plan or a gesture toward taking his or her life. And suicide attempts are very dangerous. The child or teen takes the actual steps to ensure their death. However, either the child is found by another person in time to secure emergency health and resuscitation, or is unsuccessful and lives through the attempt. Such as jumping off a high bridge and they survive with full attention of death, but living through the jump. Suicidal gesture is an attempt at suicide, but without the means to take one's life, which is a non-fatal act of deliberately causing harm or injury to self. This term is being phased out because it's being seen as admissive. Then there's a lethality of attempt, and this refers to the potential deadliness of a suicide attempt based on the patient's chosen method. And then we have the suicide, and this means death resulting from taking one's own life. So identifying risks is important, and this is any threats of suicide, and it must be taken seriously. So any inclination of the child expressing any, need to harm themselves, or have any ideation about that, you need to get them to immediate help. You need to support them. You need to stay with them. Safety is important. Usually in a hospital setting, or in a clinic setting, when they express their suicidal ideation or they will need to be, you'll need to immediately mobilize a team to provide safety. So they will be placed on 101 on a continuous observation. If they're in a hospital, their room will be cleared out. Like anything that the child can harm themselves with, like cords or wires or anything that's or curtains, they will remove them from the room. Usually non-suicidal self-injury, nurses caring for children and teens may need to be aware of the phenomenon of non-suicidal self-injuries. And these injuries are not accompanied by suicide ideation or intent, but rather ways of coping with anxiety. And such examples of non-suicidal self-injury are burning, cutting, excessive rubbing to the point where there's skin excoriation, and stabbing with various objects. So those are the things that you need to be mindful as well. And again, I'm going to repeat this, nursing considerations. Um, as I discussed before, you want to provide immediate stabilization and hospitalization with around-the-clock observation for suicide in children. Contact both Child Protective Services and law enforcement department, and search child's home for weapons, drugs, and access to medications. And nursing care based on trauma, which if they've had poison ingestion, or ensuring evaluation by a child mental health clinic specialist. Non-suicidal self-injury, which I just briefly mentioned, is usually injuries that are not accompanied by suicidal ideation or intent, but it's just to cope with their anxiety. Such behaviors are, as we said earlier, are burning, cutting, excessive rubbing to the point, skin excoriation, and stabbing with various objects. Okay, moving on to schizophrenia, which is a chronic, severe, and disabling psychiatric disorder, and it's usually characterized by delusion, hallucination, disrupt thought disorder. The child affected appears to be in a chaotic state with paranoid delusions. Hebephrenia, which is an inappropriate silliness, laughter, and mannerisms, or reduced expressions of emotion. That's what that means. Alternating moods, aggressive behaviors, or social withdrawal. The diagnosis of schizophrenia is typically made in the late teens to early 30s, with symptoms of being demonstrated earlier in males. The patient experiences thinking that is completely out of touch with reality. He or she may hear voices that are not there. They see people who are not present, or they suffer physical symptoms of bugs crawling on the skin. Adolescents with schizophrenia may experience paranoia, and they feel as though people are plotting against them. And it's really these are the statistics of the prevalence of schizophrenia in the United States. It's usually 1.5 times more males than females. Evaluation is usually diagnosing in children is complicated, and it must be done by professionals who are experienced and trained in that area. Because of the severity of the disorder, assessments include behavioral and emotional symptoms, delusions, disordered thinking, disordered speech, hallucinations, and impaired ability to function are all evaluated. If the child is young, early symptoms to assess for include late crawling and walking, delays in language development, and abnormal motor movements, such as arm flapping and persistent rocking. But because there is so much overlap between these symptoms of ASD, of autism spectrum disorder in a young child, it is essential that an experienced and well-trained healthcare provider assess the child's accurate diagnoses. There is no single treatment. They must continue throughout lifetime. So usually treatments must continue throughout the individual's lifetime. The child may benefit from neuroleptic medication to manage some of the symptoms of the disorder, such as hallucinations, psychotic delusions. Family involvement and commitment to the child taking his or her medications are imperative. Usually, suicide is a concern for people diagnosed with schizophrenia. And usually with 4.9% taking their own lives in early phases of this illnesses. So this is something that you really got to be considered, because this is a really it's a stressful, it's a very heart-wrenching illness. My cousin was diagnosed with this. She was actually in college when she was diagnosed. She was brilliant. She was actually considered as a genius level. She was actually going through nursing school, and then she had the idea of continuing on to be a medical doctor. But she started having hallucinations. She was self-medicating. Her symptoms were becoming more erratic, more impulsive, more paranoid, and psychotic episodes. She's been in and out of frequent hospitalizations and she's now institutionalized because she cannot function independently. She would be okay throughout her life. She would be discharged from these institutions for months, sometimes years, and then she'll have her own apartment. She'll be doing really well. And then she thinks because she's doing really well that she doesn't need her medications anymore. She stops taking her medications, and these hallucinations and delusions start to come back. She had an apartment and she spray painted inside of her apartment on herself. And then she was in the middle of the road, literally, banging on cars. She was literally in the middle of the road, like punching on the cars. And eventually 911 was called and she was hospitalized. And from that point on, um, she's now in an institution now, more assisted living, where she's monitored more and um, in a place where they can monitor her medications and ensure that she's taking them. So it's a hard life for both the family and for the patient itself. Nursing considerations is a strict follow-up and want to monitor for medications and side effects like tardive dyskinesia, which is a big one. It's a serious side effect of neuroleptic medications. The symptoms are usually involuntary twisting and writhing of the face, limbs, and trunk. It can be reversible if they occur during the withdrawal or the discontinuation of the medication. It could be irreversible if it develops during a drug therapy. Neuroleptic management malignant syndrome is something to be mindful of that as well. It is a rare side effect that is characterized by a lead pipe, which is stiffness of the extremities and high fevers. For patient safety, it is imperative to regularly ask families about the development of the early side effects. Moving on to substance use disorder, about 15% of children in the 8th grade report the use of at least one illicit drug in the prior 12 months. And usually about 50% of adolescents report that they have been drunk or abused a drug within the last year. Some teens try to illicit substances only a few times, and others develop cravings and urges that lead to abuse. So those are pretty much the statistics of substance use disorder, and it's commonly used substances. I'm like, oh, bring it here. Let me drink something here. Commonly used substances include tobacco, marijuana, alcohol, stimulants like Adderall, hallucinogens, steroids, inhalants, prescription drugs. You get the idea. So parents, assessing signs and symptoms of alcohol and drug abuse in children and teens. Parents need to be taught on how to assess for that. So, and be aware of the symptoms, which are general changes in their overall attitude, sudden personality changes that disrupt school attendance or grades or extracurricular activities, sudden outbreaks of anger, aggression, nervousness, and jitterness, increase secretiveness. They're very secretive, want to hide everything. If they have engagement in the new social circle of friends who have no interest in meeting the family, withdrawal from responsibility. They'll have some red eyes or complaints of being overly tired, loss of interest of hobbies, activities, and sports that they were previously engaged in, loss of interest in personal grooming, hygiene, and personal appearance, or borrowing or stealing money or objects to sell association with known substance abusers. So, and also frequent trips to the bathroom, storage areas, basement, or other places where drugs and alcohol could be stored. So those are things that you mindful of as well. As I said in the previous slide, these are the things that are children at risk. Usually living in homes where substance disorder occurs. They experience depression. They do not feel valued by their parents. They assess for, and I discussed earlier slide, assessing signs and symptoms of alcohol and substance use in children and teens. So I already discussed that. So parents need to acknowledge that the child has substance use disorder and seek information, help, and treatment for the child. So there's a lot of rehabilitations that are available for pediatrics. It's kind of, that is a limited resource throughout the nation. However, it is very expensive. I mean, when I worked at a alcohol and drug rehabilitation facility, and it was quite expensive. And I remember talking to the mother of one of the clients, we call them, one of their sons who was a addict. This was his 10th time being admitted for drug and rehab. He was, I think it was on heroin, but she had to put a second mortgage on her house. Because for a month, I think just for a month of these treatments, it's about 10,000 or more, 14,000. And this kid has been, that was his 10th time being in there. So it can be very costly. And the parents are really, puts them through a lot. Sometimes they can be enablers. They're just in denial that their loved ones, or they'll just do anything they possibly can to keep their child alive. It's a heartbreaking illness. They always say it's by choice, but it is an illness, and it should be treated as such. Evaluating substance use disorder, you want to determine whether the use is causing the problems with the person's health. For a school, home life, or relationships. Look out for physical and affective signs. Warning signs, as we mentioned before, is worsening in academic performance, problems with relationships at home, they isolate themselves, or sometimes there is presence of a family member who has or had an addiction problems. The condition compulsively seeking and using substance despite harmful consequences. So usually they have a history of that in their family. Interventions are medications, whereas naltrexone, bupropion, and methadone, and psychotherapy, behavior modifications, cognitive behavioral therapy, 12-step programs, or peer group therapies. Those are all the interventions for substance use and treatments for that. There's a lot of there's a lot of organizations and that can help provide education and support families who have childhood participating in substance abuse. And such organizations include Alcoholics Anonymous, which is AA, National Institute of Alcohol Abuse and Alcoholism, Kids Health, National Institute of Drug Abuse, and Partnership for Drug-Free Kids. So those are such organizations and resources that we can provide for the family to support their loved one, for their child. Interventions, there's 3 important considerations for substance use disorder. You want to be mindful of the child's physical needs. They must be met, including withdrawal symptoms. The child cognitive and emotional needs have been affected by the addiction, and the child's family dynamics will need to be repaired if the trust will need repair if trust has been broken. So there's going to be a lot of family counseling if they need it, or and also if the addiction has had a severe consequences on family relationships. Unfortunately, a lot of these teenagers could be homeless, or they actually leave their homes and never talk to their families because it's always been a repetitive. There's a lot of hard dynamics within that. So those are the things that to be considerate about when it's taken care of with an adolescent or child with substance use disorder. additional nursing considerations. You want to help them secure professional intervention, which is those organizations that I mentioned as well, or inpatient. Teach parents to immediately contact healthcare provider if substance use disorder is suspected. You want to secure educational advocate. Encourage parents to educate their children and communicate family values and set rules and consequences. If there's a child, you can actually, usually they have Narcan kits actually available free to families. You can provide them or point out where they can get them. The ER, when there's somebody comes in with an overdose, we always give them a Narcan kit. So we give that to them for free and they will go home with that. And this is just to reduce any suicide or drug overdose. Teach parents to keep narcotics and other medications away from family and reach a site. Inform patients on organizations that provide education and support for families who have had a child with a substance use disorder, which I mentioned earlier. And then we're going to move on to bullying, which is a national concern. It seems to be on the rise these days, especially because a lot of children have easy access and modalities to use to bully their peers. It has many forms, and this includes physical force and violence, spreading rumors about others, social exclusion, severe teasing, like ganging up on others, or they're using social media, which is becoming popular, to send insulting, obscene messages or pictures. And victims often display low self-esteem, loneliness, anxiety, depression, poor academic performance, and suicidal thoughts. Victims can experience poor physical health, including headaches, sleeping problems, GI stress, which probably accompanies with the anxiety and other anti-inflammatory processes. So bullying is known to cause long-lasting emotional scars and lifelong memories. So children who witness bullying also suffer with fear, guilt, and distraction in schoolwork. So it can begin as early as later preschool period. And bullies may choose their victim at random, or they may persecute children who look different, such as those who are obese or small stature or have unique features. Sometimes bullying victims have learning disabilities or they developmental delays, or sometimes they have mental illness. Um, Assessing for bullying is important and may save lives. And you want to try using questions such as, are there any kids at your school who tease you in a mean way? Or are there kids at school who you really do not like and why? Have you been harassed on social media? Those are just questions that you can ask them. You want to look for physical and emotional signs of bullying, obvious signs of physical bullying, which can be cuts, bruises, black eyes, torn personal belongings, or damaged school supplies. Other signs may be extreme school aversion, frequent, so they might want to skip school, they'll pretend to be sick, symptoms of depression, somatic complaints such as stomach aches, poor school performance. Usually bullies choose their victims who are less powerful than they are and who are different in any way of them. Interventions, this is for school personnel. You want to ideally stop before the child's hurt. You want to stand between the child involved. Block eye contact between the bully and the victim. You don't want to sort out facts and do not reason at the time of the incident. Have bystander witnesses of the intervention. You want to state out loud. The behaviors that you saw and heard. State clearly that bullying is against the rules and will not be tolerated. And there's a bully side, which is considered to eradicate bullying. Nursing considerations is under no circumstances can bullying be allowed within a healthcare setting. Any bullying must be stopped and interventions implemented. Healthcare team can call the school to report the child's experiences, and social workers should be notified. So request a referral for a child psychologist, and a bully child needs to be referred for help. Ensure the family knows to contact school authorities who should have protocols for intervening in bullying. And that's it.